is a close friend and a brilliant cataract refractive surgeon based in Bombay, and I'm grateful to him for having left his own IC and come here for the talk. So thank you for that, Nikhil.
Good morning, everyone. So, I'm going to be covering the topic of recorrections when and how. So, we have many patients who come to us post refractive surgery complaining that their vision is blurred. And it's very important that we first evaluate the same before going ahead and doing anything for them. So, I'm going to be doing a case wise discussion. The first case is of a 28-year-old male. Having undergone LASIK 2 years back, who's now complaining of blurred vision in the left eye since 1 year. His right eye vision was 6.6, left eye vision from 6.18 improving to 6.6. This patient had a clear interface, normal fundus. If you see, it's a very well-centered ablation out here. He had a very normal epithelial map. When we did the dry eye test, there was no evidence of dry eyes. We waited for 6 months to see if this refraction was stable or not. There was a very stable refraction. There was no further regression happening. So in this case, what we did do is relift the flap and recorrect it. And why did we relift the flap is because within the first 3 years, the chances of epithelial ingrowth is usually much lower. It's as less as 1%. Coming to the second case is of a 34-year-old male who had LASIK 6 years ago, complaining of blurred vision in both eyes since 4 years. His vision had dropped to 612 parts and 618 parts, and he had a slight spherical and a small cylindrical error too. Again, the interface was clear. There was no evidence of dry eye, centered ablation, good pachymetry, and normal epithelial maps. Again, we waited for 6 months, but what we saw after 6 months is that his vision had dropped even further and the refraction had increased. So, this being to the fact that there was an increasing axial length in this patient, and hence such patients should not be taken up for recorrection, as this is a case that the axial length is constantly increasing. It's not going to stabilize. So, even doing a recorrection is not going to help because there would be a regression following that again. Fine. Coming to the next case, a 27-year-old IT professional had LASIK 3 years back. The vision in both eyes had dropped. She had frequent headaches, and her cycloplegic refraction in this case, the right eye, she was plano and left eye accepting just a 0.25, but she had a myopic error on the undilated AR. So what we did in this case is that we did her evaluation using the Binox tool, and what we got from that is that she was excessively accommodating. She was a computer user, and in such patients, this is actually a pseudo regression. We should not be correcting it. We gave her orthoptic exercises with flippers for the correction of the accommodation excess, and after 20 sessions, the patient is now reading with plano. So there's absolutely no need of a correction in such a case. Coming to the next case, it's of a 31-year-old female having LASIK 9 years back. Now she complains of blurred vision since the last 2 years. She had a history of pregnancy 2.5 years back, and the vision in her right eye had fallen with a cylinder of almost 2.5 diopters. Here we see in all the anterior, the posterior maps, and in the corneal thickness maps that she had actually developed a post-LASIK ectasia. Obviously, such cases, there's no question about a recorrection. We took her up for corneal cross-linking was performed to prevent the progression of the ectasia. Coming to the next case, this is of a 30-year-old male. He had LASIK elsewhere 3 years back and was now complaining of blurred vision post the LASIK. His preoperative refraction when we got it from him was a 5.5 in the right eye and 5 in the left eye was what was corrected. It was a hyperopic LASIK. It was a good post-op topography with a centered ablation. And what we did do in this case is, again, we did not recorrect right away. We waited for 6 months with just the lubricant use. And after 6 months, we saw that his vision had already improved with just a 0.25 in refraction. And this is because usually overcorrections are often planned during hyperopic LASIK to prevent latent hyperopia to set in after the LASIK and to compensate for some degree of regression. So if a patient comes away, you should not be directly recorrecting them for the small residual error, but actually wait for a while, which automatically due to the regression, it corrects itself. Coming to another case, a 33-year-old male having had LASIK elsewhere, complaining of blurred vision, glares, halos following LASIK. And what we see here was a decentered ablation. So in such a case, it is very important to do, if you can, do a topo-customized ablation to get the cell-turned ablation again. There's a lot of study done at my alma mater, Narayan Nethralaya, on the same. Um, Coming to one more case, a 31-year-old male having undergone LASIK 13 years back. It was done at the age of 18, and he wanted to join the merchant navy at that time. He now complains of blurred vision in the left eye. His preoperative refraction from his records was this. He had a well-centered topography postoperatively, but his central corneal thickness was 443 microns. The thinnest corneal was 421 microns. What we did is we did an OS, an anterior segment OCT, and we saw his flap thickness was roughly around 110 microns. So we realized that we did our calculations here. We needed the refraction which needed to be corrected right now was a 1.5 diopter. He had obviously done this at the age of 18 when the refraction wasn't stable, and now that he's gotten the number, we decided to correct it. The refraction to be corrected was 1.5 diopter using the optical zone of 6 millimeters and the flap of 110. The residual stromal bed would come out to be somewhere around about 291.5 microns, which was too minimal, and hence we decided not to relift in this case. Instead, we decided that if we do a surface ablation, what we'll actually be ablating is from the LASIK flap itself. The LASIK flap being 110 microns, we would be just ablating round about 55 for the epithelium and round about 20 microns for the actual correction. So we went ahead with a surface ablation in this case. Finally, coming to a last case, a 28-year-old female who had developed blurred vision after LASIK, who done 6 months ago. It's a case, obviously, we had seen that there was epithelial ingrowth as seen in the anterior segment OCT2. What we decided to do is just lift the flap and do a good interface wash. I think they've... anyway, I
Okay.
think I'll conclude
Yeah.
here in the presentation's gone off. Thank you, Dr. Tushar.
Thanks a lot, Dr. Nikhil. You've summed up everything very well, and not everything is a regression. So you've shown what are the possible reasons why we can have myopic refractive errors or any refractive error after